So hey guys, welcome to my new video, and today we will be talking about diabetes mellitus. Now, what basically is diabetes mellitus? So diabetes mellitus, it is a metabolic clinical syndrome which is characterized by hyperglycemia and relative deficiency of insulin. Okay, now also in diabetes it is a metabolic clinical syndrome. Okay, metabolic clinical syndrome means the protein metabolism, carbohydrate, lipid metabolism is also affected. So in carbohydrate we see hyperglycemia. Okay, in lipid we see lipolysis and lipogenesis, which leads to increase in triglyceride level further. Okay, and in protein synthesis we see breakdown of proteins, and this leads to gluconeogenesis. Okay, so this is the basic pathogenesis and the definition of diabetes mellitus. Now going further with the types. Okay, the types of diabetes mellitus. We have, just a second, we have type 1 diabetes mellitus, and we have type 2 diabetes mellitus. Okay, also we have a third type, gestational diabetes mellitus. Okay, so in type 1 diabetes mellitus, the pathogenesis is that the beta cells of pancreas are destroyed. Okay, sorry. Type 2 diabetes mellitus is characteristic by the beta cells of pancreas are normal, but peripheral resistance to insulin. Okay, so in type 1 we see the problem in the biosynthesis of the insulin, and in type 2 we see that the peripheral resistance of insulin is increased. And gestational diabetes mellitus observed in pregnancy. Okay, now we are talking about glucose a lot. Okay, like the diabetes mellitus, it is characterized by hyperglycemia. So now seeing the levels, normal levels of glucose, so let me just write the heading glucose. Okay, let me now just write the headings and I will come back in a second. So these are the headings. So what I have basically written is the normal glucose level, okay, the pre-diabetes and the diabetes, and what are the parameters: pre-prandial, post-prandial, and HbA1c. Okay, pre-prandial means before meals, post-prandial after meals, and the HbA1c levels. Now the normal glucose level in pre-prandial is less than 100 milligram per deciliter. Okay, and in diabetes the pre-prandial must be less than 126 milligram per deciliter. Okay, then postprandially, normal postprandial is less than 140 milligram per deciliter. The diabetic condition postprandial is less than 200 milligram per deciliter. The normal HbA1c is less than 5.6 gram per deciliter. Okay, now note this, it is gram and this is milligram. And in diabetes, the HbA1c is more than 6.5 gram per deciliter. Now you will notice that I have kept the pre-diabetes row very clear. So logically speaking, it will be a range 100 to 126 milligram per deciliter. Then here 140 to 200 milligram per deciliter. And here it is 5.6 to 6.5 gram per deciliter. Okay, so this was the normal pre-diabetes and diabetes levels of glucose in preprandial, postprandial and HbA1c conditions. Now let me just write one point. If it is normal, if it is pre-diabetic condition, and if it is diabetic condition, so what we will write? The treatment. Normal, it will have no treatment. Pre-diabetic, treated by lifestyle modification. Okay, and diabetic, of course, it is treated by drugs. So this was the normal glucose, pre-diabetes and diabetes glucose ranges. Okay, now till now we have covered what is diabetes mellitus. It is a metabolic clinical syndrome which is characterized by hyperglycemia and decreased insulin secretion. Okay, the types: type 1, type 2 gestational. Type 1 is beta cells of pancreas are destroyed. Mainly the etiology is autoimmunity. Type 2 diabetes mellitus, it is due to increased resistance of insulin, peripheral resistance of insulin, and gestational diabetes mellitus is observed in pregnancy. The glucose levels in preprandial, postprandial, HbA1c levels, normal, prediabetes, diabetic range. Okay, and the treatment of each of them. Now we are talking about glucose, hyperglycemia, insulin a lot. So we have covered glucose and hyperglycemia. Now it is time that we cover insulin. Okay, so basically at first we will see the basic information of insulin. Then we will see the classes of the drug used to treat diabetes, and then we will again start with insulin. Okay, now what is insulin? Okay, insulin is basically a molecule which is a polypeptide chain having two chains, A and B, and these two chains are joined by disulfide bonds. Okay, now the formation of insulin. Okay, now first we have pro insulin, we have then pro-insulin, and this pro-insulin further splits into our regular insulin and C-peptide. Now I am highlighting this C-peptide because it has two importance. What are the two importance? So let me just mention the two importance here. Remember, we said that there are two types of diabetes, mainly type 1, type 2, and gestational is observed later in the pregnancy stage, but pathology is type 1 and type 2. Okay, so type 1 diabetes mellitus, it is due to beta cells of pancreas are destroyed, and type 2 is due to beta cells of pancreas are normal but peripheral resistance of insulin is increased. Now tell me one thing, if a patient comes to you and he complains about the typical feature of diabetes, okay, Now, how will you distinguish between the two diabetes? So basically, this C peptide will help you in this. What we said is the type 1 diabetes mellitus, it is due to destruction of the beta cells. So we do not have insulin in the body. So tell me one thing, the C peptide, will it be produced or not? Yes, it will be not produced. Then in type 2 diabetes mellitus, the peripheral resistance of insulin is increased. Okay, since the peripheral resistance of insulin is increased and the beta cells are normal, the beta cells will continue to produce insulin. Okay, this procedure will be continued and this will be formed. Okay, so you understood that in type 2 diabetes mellitus, we will see that the C peptide levels in the blood is normal or it is slightly decreased. But in case of type 1 diabetes mellitus, we will see that the C peptide is absent in the blood. So first importance is to distinguish between type 1 and type 2 diabetes mellitus. Okay, now the second importance, it is a marker of insulinoma. Okay, so this was the importance of C peptide. This was the synthesis of insulin. Okay, now one very important point to note, and this is one of the keyword which will help you to remember many of the things. Okay, so one important point, that insulin is an anabolic hormone. Okay, what is meant by anabolic? Means to join, and what is meant of catabolic? Means to cut. Okay, so since it is an anabolic hormone, don't you think that these features which we have shown earlier about the lipids, lipolysis, about protein breakdown, hyperglycemia, so it will be reversed? Yes, so insulin basically reverses this effects and it is a anabolic hormone. Now the pattern of secretion, this is very important for our insulin in the body. Okay, so we will draw a graph. Okay, so the y-axis is, it says insulin level, and x-axis shows the time period. Now the pattern of secretion of insulin is like this. Just a second. So ideally this should be the pattern of secretion. Okay, so what is this pattern of secretion? So now we have two types of insulin in this. This one which you see the straight line, it is the basal insulin. Okay, and this peaked one, like this full peaks. Okay, these are known as the bolus insulin. Okay, and each insulin, these two types have their own significance. Now tell me one thing. I said one thing while telling you the pattern of secretion, that ideally this should be the graph. Ideal means this is the breakfast, this is the lunch, and this is the dinner. So when you eat something, okay, it contains glucose, then the glucose needs fixation. So what will happen? Suddenly the glucose level of the body will be increased. Okay. Now, if suddenly the glucose level of the body increase, we need more insulin, okay, than normal. So these peaks are basically representing that the insulin levels are increased. Means we eat the breakfast, we have many of the carbohydrates going in the body, and the rise in the glucose level is seen. So to decrease that glucose level, we see increase in the insulin levels after every meals. So bolus insulin. Now, since peak is reached after the meals, okay, what does it signifies? It signifies that the bolus insulin, it controls the postprandial glucose, and highlight it, okay, postprandial glucose. Now, the basal insulin. Basal insulin, basically it is secreted every time. Insulin, it is secreted every time. Okay, now what will that basal insulin will do? We have seen many effects like gluconeogenesis. So it will inhibit gluconeogenesis. Okay, then one more effect we have seen, it will inhibit lipolysis. Okay, so these are some effect of the basal insulin. Okay, then also one effect will be glycogenolysis, and one effect also ketogenesis. So basically we see a anabolic effect of insulin. So that's what insulin says, like the body insulin. Okay, we are yet to talk about the drugs. So till now we have covered with the insulin, the basic information about insulin, formation of insulin, and we have also seen the pattern of secretion. One point I would like to add in this insulin, A chain and B chain. Okay, so we have A chain 21 amino acid and B chain 30 amino acids, and aggregately of course it will be 51 amino acids. Okay, now we will talk about the drugs used for diabetes mellitus. So diabetes mellitus, so we have two main classes, two gross classes of drugs. Okay, we have insulin and we have oral hypoglycemic drugs. Okay, so under insulin, okay, we have the following classes named as ultra short acting insulin, then we have short acting insulin, we have intermediate acting insulin, we have long acting insulin, and we have ultra long acting insulin. Okay, under oral hypoglycemic drugs we have further two classifications. Okay, the classification says the drugs acting on pancreas and drugs acting peripherally. Okay, so now we have mnemonics for them. The mnemonic for drugs acting on pancreatic: smart, made. Okay, so the classification says sulfonylureas. We have meglitinides. We have amylin analogs. We have incretins, the GLP and GIP analogs, and we have DPP4 inhibitors. Okay, and under peripherally acting we have the mnemonic BATs. Okay, so B for biguanides, the very famous class, because the famous drug metformin comes under this class. Then we have alpha glucosidase inhibitors. We have thiazolidinediones. Okay, thiazolidinediones. Okay, this is not a very famous class because the name is too complicated, so I too also avoid this class. Now we have SGLT2 inhibitors. Okay, so this is the classification of the drugs of diabetes mellitus. Okay, under classification we see two types, insulin and oral hypoglycemic drug. Under insulin we see ultra short acting, short acting, long acting, intermediate acting, long acting, and then ultra long acting. Under oral hypoglycemic drugs, the further classification is the drugs which acts on the pancreas and the drugs which acts on the peripheral organs. So under pancreas, the drugs affecting the pancreas, the mnemonic says SMART made. SMART made stands for sulfonylureas, meglitinides, then amylin analogs, then we have the incretins, we have the DPP4 inhibitors. Under drugs acting on peripheral organs, we have the class, we have the mnemonic BATs. So BATs stand for biguanides, then alpha glucosidase inhibitor, then thiazolidinediones, then SGLT2 inhibitors. Now for this video we are only concerned with the insulin. Rest oral hypoglycemic drugs will be covered earlier. Okay, so now we will start with insulin. Now starting with insulin. Okay, in insulin, the mechanism of action of insulin. Okay, so let me draw one diagram, a very nice diagram, okay, of the cell membrane. So this is the diagram of the cell membrane. Okay, so this blue one is cell membrane. Okay, this red is alpha receptors. Okay, this green is beta receptors. Don't confuse it with alpha and beta cells present on the pancreas. These are the receptors on the cell membrane, alpha receptor, beta receptor. And as you can see, let me just mention first, this is the extracellular, this is the intracellular site. Okay, now the alpha receptors are extracellular while the beta receptors are transmembrane receptors. Now what happens is, at first insulin comes. Okay, now it binds to beta receptors. Okay, now when it comes, it binds to the beta receptor. What it will cause? Beta receptors are transmembrane protein. Okay, they have the tyrosine kinase activity. Okay, so beta receptor, at first we will draw flow chart for mechanism of action. Binding of insulin to beta receptors. Okay, basically these are the subunits, beta receptor subunits. So calling it as an individual receptor will be wrong. They are subunits of the same receptor. Now this binding, okay, beta subunit has tyrosine kinase activity. Okay. Now what happens is, due to this binding of insulin to the beta receptor, there will be complex phosphorylation and dephosphorylation reactions, and this will lead to entry of glucose in cells will be facilitated. So repeating the mechanism of action from the start, the cell membrane has two subunit of the same receptor known as alpha receptor subunit and beta receptor subunit, where the alpha subunits are present extracellularly and the beta subunit are present on transmembrane subunit receptors. Now what happens is, insulin comes, it binds to the beta receptor subunit, it has tyrosine kinase activity, so random complex phosphorylation and dephosphorylation reactions will be there, so this will lead to entry of glucose in cells. Okay, so this is the mechanism of action. Now we have seen some classes, some 5 classes. So what were they? Ultra short acting, short acting, intermediate acting, long acting, and ultra long acting. Okay, now short acting, starting with the ultra short acting. So ultra short acting, they are basically the drugs made by interchanging amino acids on the chains. Okay, so what does it means? So basically they are made by interchanging the position of amino acid. For example, we have Lispro. Just a second, we have Lispro. Okay, then we have another drug named as Aspart. Then we have Glulicine. Okay, now these are monomeric insulin, means one molecule of insulin is present. Okay, route is subcutaneous and duration of action is 3 hours. Okay, now short acting. Sorry. Now short acting insulin, these are hexameric insulin. Now hexameric, basically what is hexameric? Now first we will write one point and then we will draw it. Okay, hexameric insulin associated with zinc. Okay, so what is this hexameric insulin associated with zinc? So now there will be one molecule of zinc and we have 6 molecule of insulin. Okay, so it will prolong the duration of action to 6 hours. The route of administration is subcutaneous, and the example is our regular insulin. Okay, subcutaneous also we can give it as IV injection. Okay, so 6 hours, 6 to 8 hours. This was all about the short acting insulin, which are associated with zinc, our regular insulin. Then we have the intermediate acting. So intermediate acting, it is also associated with some molecule. We will also draw its picture. Okay, it is also known as lente insulin. Okay, we have one example in this. We will write the example and then we draw it. We have NPH. It stands for neutral protamine hagedron. Okay, and the structure is NPH will be at the middle. Protamine will be at the middle. Protamine and insulin will be attached to it. Okay. The duration is around 10 hours. Okay. Now we have long acting insulin. Okay, long acting means it acts for around 18 to 24 hours. Okay, two drugs to remember: Detimir and Glargine. Okay, they are given once daily at bedtime because it is for 18 to 24 hours. Okay, they are peakless insulin. Okay, what is peakless insulin? We will study when we complete all the classes. We will draw one diagram, okay, on graph basically. There we will be understand that what are peakless insulin. Okay, and long acting cannot be mixed with other insulin. Okay, now since we have reached till long acting insulin, we are ready to know one more concept. Now this pattern of secretion. Okay, pattern of secretion. So when a person eats a meal, okay, now if for example he eats the breakfast, so we will require some insulin which is very short acting and the onset of action is more, onset of action is less. Okay, and in the intermeal period, the basal insulin, we will require the basal insulin. Okay, so we give a combination of a long acting or a ultra long acting with a short acting or a ultra short acting. Okay, so that after meals the ultra short or short acting will control the postprandial glucose levels and the basal insulin will cover the basal level in the intermeal period. So the basal insulin is the long acting or ultra long acting. So insulins are mixed. Okay, these insulin are mixed and we see the effect, but long acting insulin, they cannot be mixed. Okay, and why they cannot be mixed? The reason is very important, due to acidic pH. Reason is very important. Okay, now we have ultra long acting insulin. So we have one example in this, Degludec. It acts for 42 hours. So a subcutaneous injection once in 2 days is given. Okay, and hypoglycemic risk. Okay, so tell me one thing, if the onset of duration is less, will the hypoglycemic risk will be more, or if the onset of duration is more, okay, the hypoglycemic risk will be more? Yes, you are right. If the onset of duration is more, hypoglycemic risk, sudden hypoglycemic risk will be less. Okay, So now we have some examples. We have a note, okay, some fixed dose of insulin. So Lispro, which was a ultra short acting, is combined with NPH, which was a intermediate acting, and the ratio is 30:70. They are mixed. Okay. Now Lispro will be the bolus insulin, and NPH, neutral protamine hagedron, will be the basal insulin. Another insulin is combined regular insulin and NPH. So regular insulin was a short acting insulin and NPH is a intermediate acting. The ratio is 50-50, and regular will be bolus insulin, NPH will be the basal insulin. Okay, they are mixed in same subcutaneous injection. Okay, and these are also known as mixed-tard insulin. Okay, another preparation we have glargine. Let me just write glargine or degludec with Lispro, but one huge but sorry, BUT. Okay, a huge BUT. They are not combined, and we have saw the reason earlier, because of acidic pH. They are given in separate subcutaneous injection. Okay, now it's time to draw the graph finally. Now the graph says that levels of insulin in body versus time. Now tell me one thing, ultra short and short acting, what will be they? They will be bolus insulin. Okay, so they will act as a bolus insulin. So the onset of action is also, just a second, the onset of action is less and the duration of action is also less. Okay, this is the ultra short. What has happened to this? Okay, and this will be the short acting. Just tell me one thing, the duration will be 3 hours, here 6 hours. Now we have intermediate acting. Intermediate acting will have a lesser peak comparatively. The peak will it will decrease. Okay, so this is for around 8 to 10 hours. Now one thing, we have the main insulins now, the ultra long and long. So under long acting we will see the onset of duration is more lesser and the peak is also reduced. Okay, and same goes with ultra long. The peak is reduced, the onset of action is reduced, but the duration of action is prolonged. Okay, duration of action is prolonged. So this is the insulin, which is the long acting, and this is the insulin, which is the ultra long acting. So since they have no peak, okay, they are called as peakless insulin. The peak will be reduced as the duration of action, the onset of duration is more for long acting, ultra long acting. Okay, so this is the bolus insulin. This is also one of the bolus insulin, and the peak goes on decreasing. Okay, you can see that the peak goes on decreasing. Why? Because the onset of action, okay, this is the onset of action. Onset of action keeps on increasing and duration of action keeps on increasing. Okay, and therefore the ultra long and long acting insulin are also known as peakless insulin. Now we will talk about the adverse effect. Okay, the adverse effect of insulin. So one logical effect, since it causes hypoglycemia, so hypoglycemia may be one of the adverse effect, like sudden hypoglycemia. Okay, then we have, since the insulin is an anabolic hormone, we will have weight loss or gain. Anabolic hormone, yes, we will have weight gain. Then one more effect, we will have hypokalemia, adverse effect, and one very very important effect, lipodystrophy. What is lipodystrophy? Basically, when we give insulin injections on the same site, and if the needle or something is affected or it is not sterile enough, so what happens is the surrounding fat will get like accumulated, and it will be abnormally accumulated at the injection site, regular injection site. So that is known as lipodystrophy. Okay, now the main uses. Okay, we already studied about the uses in like indirectly, but the main uses is in type. Okay, this is the most like tricky question. In which type will insulin will be more effective? Yeah, in type 1, effective and preferable. Type 1 diabetes mellitus. Why not oral hypoglycemic drugs are not the main drug of choice for type 1 diabetes mellitus? Remember, in type 1 diabetes mellitus, we have complete loss of insulin. Okay, so even if we give oral hypoglycemic drugs alone, what happens is oral hypoglycemic drugs require some amount of insulin in the body for its action. You will study it in earlier section. But if you give insulin directly, you will see more potent and more effect. Okay, so oral hypoglycemic drugs are given as an add-on drug. Okay, and then these are the uses, the drug of choice for type 1 diabetes mellitus. Just a second. Now some sites. Okay, we will write some sites. So one is buttocks, then abdomen, but in abdomen not given 2 centimeter, not given 2 centimeter, like let me frame it, 2 centimeter distal to umbilicus. Okay, for example, this is the umbilicus, so 2 centimeter distal, we will not give in this area. Okay, we will give 2 centimeter distal to the umbilicus. Then we have lateral aspects of thigh, lateral aspects of thigh, we have the arm region. Okay, so these are the some sites where we can give this injections. Now route of insulin. So we have the main route, subcutaneous route, we have the intravenous route. Intravenous preferred in emergency. Okay, where we give in emergency, the drug of choice is IV regular insulin. Okay, then nasal, intranasal route. So we have to remember intranasal route, one drug, Afreeza. So it is an intranasal drug, it is a powder basically. Okay, dry powder. It is very short acting, very short acting. Okay, we have side effects also, like we can get asthma, we can get hypersensitivity reaction, other hypersensitivity reaction which is confined to the respiratory system. Then we can give lung cancer. Okay, we can get lung cancer, and it is contraindicated in smokers. Okay, so this was all about insulin. So we started with the definition of diabetes mellitus. We then studied the types of diabetes mellitus. We saw the glucose and the glucose levels and the treatment of each level. Then we saw insulin as a gross hormone of the body. Okay, then we saw the pattern of secretion of insulin in our body, the main thing. Then we saw the diabetes mellitus, the classification of drugs, in which there are two major classes, insulin and oral hypoglycemic drug. Under insulin we have ultra short, short, intermediate, long and ultra long. Under oral hypoglycemic we have drugs acting on pancreas and drugs acting on peripheral organs. We have drug acting on pancreas, the mnemonics is SmartMade. SmartMade stands for sulfonylureas, meglitinides, amylin derivatives, incretins and DPP-4 inhibitors. Under peripheral organs we have BATs. BATs stand for biguanides, alpha glucosidase inhibitor. We have thiazolidinidones, and we have SGLT2 inhibitors. Then we saw insulin. In insulin we saw the mechanism of action of insulin, where we have alpha and beta subunits of the receptor. The beta subunit, like the insulin gets bind to the beta subunit. Now the beta subunit has tyrosine kinase activity, so phosphorylation and dephosphorylation reaction occurs, which leads to the entry of glucose in the cells. Then we saw the classes, ultra short, which contains lispro, aspart and glulicin. Under short we had regular insulin. Under intermediate we had NPH, neutral, protamine hagedron. Then we in long acting we have glargine and degludec. Under ultra long we had degludec. In long acting we have glargine and detimir. In ultra long we have degludec. Okay, and we saw the fixed dose combination, lispro and NPH, given in same syringe. Okay, same subcutaneous injection, lispro and NPH in the ratio 30:70, and lispro and regular insulin and NPH in 50:50 ratio. Then we saw the graph plotting, which is very more important, and the concept of peakless insulin. Then we studied the adverse effect of insulin, which consists of hypoglycemia, weight gain, hypokalemia and lipodystrophy. Uses we saw type 1 diabetes mellitus, drug of choice. Then sites, various sites, and the route, subcutaneous, intravenous and intranasal. So this was all about the insulin, and in the next video we will learn about the oral hypoglycemic drugs. Thank you.